Hey, what's up? How you doing? So today we're looking at pilar cyst and implantable birth control devices. So this first patient has a bunch of pilar cysts in her scalp. These are basically the brother or sister to sebaceous cysts. They are full of sebum, which is that yellow stuff that comes out, but they happen in the scalp. When that happens, they form nice small balls. So a lot of times these, you can actually make an incision and pop them out whole, as opposed to a sebaceous cyst where you have to get the punctum out and sometimes you rupture them. These also can get infected. They can also rupture, but that's a lot less common. Yeah, let's get into it. That's ridiculous. Y'all hear this? My assistant's like, no. She said no. She said no. She said, I don't wanna. I don't feel safe. Hostile work environment. Okay, that's fine. Whatever. Here, let me get you. They can hear the tomfoolery that I have to deal with. You gonna just rush off? I said, here's the camera, and you were like, no.
Your excuse was she's already got down on. I was like, well, I get down on too.
I was like, what kind of
Tom? Between the two people with the
This is ridiculous.
rather run the camera.
That's awful. So the first thing you'll notice is that this young lady has a full head of hair. I don't shave big spots in people's heads. A lot of times they get upset when you do that. So what we like to do is just go around and shave the area that we're going to make the incision. And that's usually all that's required. There's one there. There's one there. And there's one back here. So her hair is just so thick. I don't even know how she found these, but I can kind of feel it right there. So all you do is take a little bit of HIPAA cleanse. And the trick is to just kind of, see, we're just kind of shaving just a little bit. She won't miss it. So she has a little small spot there. And then the hard part is, there we go. So you just make a little incision. Usually pretty superficial. And sometimes you try and get these out without making a hole in the cyst. If you can, cool. If you can't, that's cool too. So you just dissect it 3, 6, 9, 12, and you can see I got around it. And then try and squeeze it out. So that's it. So this first one pops out just like a pilar cyst does. You make an incision, pop it, comes out, and that's it. Then we'll close it. So that's one. And then I'll show them all at the end. And then you just close them back up. We're not going to do stitches that have to come out, because you can imagine trying to get back in here is going to be difficult at best. And I suspect no one will ever see these incisions again. So this is really just to give the body a suggestion on how to heal. It would heal on its own if you didn't do this, but it would get hair and stuff stuck in it. And it'd just be a mess for 2 weeks.
But after about 2 weeks, it would be healed. The other problem is if you, now the hard part about, I even marked these ahead of time. Table up some more, please. And this one in the middle, there it is. Purple mark, see my purple mark. Good, thank you. This one's a little smaller. And knife. Again, a little bit of Hibiclens. That's my assistant telling how Anisha's doing such a great job on the camera. Whether she is or it remains to be seen. But the most important thing for Sally is it is not her. So this was going to be a little challenging because it's a little flatter than normal. Don't know what that's about. But again, superficial incision. Knife. So this one may have to come out in pieces. You can see I kind of got through the dermis a little bit, but not too much on that first incision. I suspect this one will come out in pieces. Have a ray tack or a lap or something. So this was a little different. It's kind of scarred in there pretty bad. So it's coming out. Ruptured. Yeah, that's it. So, and then wipe that off. What I'll use.
The second one was a little harder to get out because I believe it probably ruptured in the past. So you can see us pulling it out in pieces. And this kind of looks more like a traditional sebaceous cyst removal.
Usually do is root around in there to make sure I didn't leave any. A little piece right there. More than likely the body would just get rid of it. Yeah, that was fine. Since that one's bleeding a little bit more. You can see that scalp. All right. And then, did they go back with that other one yet or not yet? And we're going to need another chromic stitch as well. So I'll get that hair. You can imagine having to do this in our office. And the last one was kind of posterior. So The reason you have to, you can use anything, water works as well, but you have to have some type of liquid to shave, so that's why we're just using the Hibiclens that we have back here. And yes, we will numb these up. It'll just be at the end of the procedure. Okay. So. So that one has a nice little plane on it. And I am dissecting all the way down to her scalp or skull. You can hear it. So then, once I've gotten it freed up around, it's just a squeeze. And again, this one, that's just coming, don't want to come out. So instead of making her incision bigger, I'm gonna just rupture the cyst. You can see this one looks like pistachio.
This third one actually is pretty interesting because it has a dark spot in it. That dark spot is probably where it got infected or at least was exposed to the skin at one point, and the sebum oxidized. When it oxidizes, it gets that dark black color, just like a blackhead.
And it's got some different colors in it. All right, let's see if that was bleeding. A little bit. So just give her a little bit of heat. And here you go, Sally. So put your hair right there for me. Hold it here. All right. And we will give her a little bit of a stitch. And again, the nice part about these chromics is that they don't have to come out, so we don't have to go back in. You can imagine trying to go in and take out staples or something like that would be a bit much. So one more. And that's local. And we'll just give a little local here. See it swelling. We'll come back. Now it's easy because we just look for the wet spot.
Here at the end, you'll see we'll go over all three types of pilar cysts, and you can see they're in stages where it's normal, chronically infected, and probably in one episode.
Skeet. And if you come back here, I'll show you these things. So if you look right there, you can see that's the first one we removed. It's only about almost 2 centimeters. This one's about 1 centimeter. And this is that third one that had, it probably ruptured already, and that's why some of it was green. But that looks like just more of a blackhead than a regular pilar cyst in this one. Just because we don't have anything else to do. So this one typically is just all white. So that's what that should look like, but that means it was probably ruptured and got infected. So that was actually a good question. She asked, why is it brown after it has ruptured? And it's just oxidation and causes it to get brown. So that's how you know that it's ruptured. And that's really what a blackhead is. A blackhead is basically a sebaceous cyst that is ruptured and causes problems. So that's it. She'll come see me in 2 weeks and she should be fine. If not, we'll take a look at them, but I tell you, those heal about 90% of the time without any problems. And this back on. The only difference really between a pilar cyst and a sebaceous cyst is really the fact that the pilar cyst is in the scalp. Now, it does have a well-defined cyst, and it does not have a punctum like a sebaceous cyst does. So it comes out uniformly, and you don't have to do that elliptical incision you have to do with a pilar cyst, or with a sebaceous cyst, because you don't have that punctum sticking through the skin. But other than that, it's pretty straightforward. All right, cool.
All right, that's it. So next on to this birth control device. This is an implantable birth control device. It goes in the skin, usually in the upper arm. This is completely different from an IUD, which goes into the uterus. The nice part about this little device is that it sends out a steady dose of progesterone, which fools the body into believing that it's pregnant. What that means is the woman can ovulate. Now, the other thing that it does is it also thickens the mucus secreted by the cervix. So that way that sperm actually can't get to the egg to fertilize it. The third thing that it also does is also thins the lining of the uterus. So even if the sperm can get to an egg, it's less likely to implant. These are about 90-95% effective, and they last for about 3 years. So yes, hopefully she can get her family started soon. Here we go.
And then all you do is turn it up.
And has a baby.
Make a little incision.
No, I want a baby. It's just the beginning.
The hardest part about removing these is actually finding the device. And that's it. That's what it looks like.
You want to just drum about that? What do you think?
You done one? You got done one.
No, I'm
Yeah, give me some done one. So this, how long you had this in for? 5 years?
It expires in May of 3 years.
3 years, so yeah.
Really, you just numb it up, make an incision, pull the little plastic rod out, and you can see it looks like a little plastic, a very small straw, and then that's it. She should be able to get pregnant over the next month, which is ideal, maybe 3 or 4 months, depending on how her body reacts to the progesterone and the absence of it.
Is that the nosy ass Tina? Tina can't shut the fuck up for nothing. There we go. Alright, that's it.
All right, guys, that's episode 2. I can't remember what we have coming up on episode 3. Hold on, I can tell you. Let's see. Got a list right here somewhere. Again, another sebaceous cyst and a very large breast cyst. So we'll get into that on episode 3. All right, guys. Thanks for tuning in. I appreciate it. Take care.